Hello, I'm Christy Cade with the White Ribbon Alliance.
And I'm Cindy Garcon, Coalition Director of the Self-Care Trailblazer Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone: advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Trailblazer Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee, Advanced Family Planning, JPIGO, PATH, Population Services International, and most of all, White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Good morning, everybody, and welcome to the Self-Care Learning and Discovery Series. We are really excited to have you with us today to discuss the policy and legal frameworks that support self-care and the role of rights holders and duty bearers. I am Catherine Mayall. I'm the Director of Strategic Initiatives at the Center for Reproductive Rights, and I'm just going to be kicking us off today with some opening remarks. Just a quick note before we get started about the translation. So we have simultaneous translation for English, French, and Spanish, and we will have people presenting in different languages today. So we need everybody, or encourage everyone, to please select the language that you prefer from the bottom of the screen. And you can do that. There's an icon if you're just in Zoom that says interpretation, and you just select the language that you prefer, so English, Spanish, or French, unless you are able to listen in all three and want to listen to each presenter in whichever language they will be speaking in. Otherwise, please select your preferred language so that you can, so you don't lose any of the presentations. We can move on to the next slide. So as I mentioned, we're going to start with just some opening remarks about duty bearers, rights holders, and accountability. And then we are going to hear from colleagues working at the national level about how they've advanced law and policy reform around self-care. And we'll have a plenary around some of the challenges that remain and how people can use the information that we've discussed. And then we're going to discuss multi-stakeholder approaches to promoting self-care before turning to our expert roundtable, who in the expert roundtable, we have 3 experts who will be speaking about the challenges and opportunities around self-care law and policy. We can go on to the next slide. So to kick us off, I just wanted to say a few words about the importance of legal and policy frameworks in either promoting or stifling the use of self-care. And the need for legal and policy frameworks on self-care has never been more apparent than over the past year or so, as we've all seen health systems, individuals, and governments confronting the effects of the COVID pandemic. So, of course, as all of you on the line know, the COVID pandemic severely exacerbated existing barriers in timely access to sexual and reproductive health services, with poor and marginalized groups shouldering the greatest burden. And we saw things such as restrictions on movements, including lockdowns, travel restrictions, and shutdowns of public transportation, rendering sexual and reproductive health services completely inaccessible for many. We also saw supply chain disruptions that further hindered access to care, with medication and contraceptive shortages resulting in unintended pregnancies, increased unsafe abortions, and amongst other effects. We saw a number of countries, though, lift legal and policy barriers on self-care and sexual and reproductive health and rights, which has been a bit of a silver lining as we think about the legal and policy framework for self-care. So, for example, we've seen countries lift restrictions around the use of medication abortion and injectable contraceptives in response to the pandemic. For example, France enabled doctors and midwives to prescribe medication abortion via teleconsultation, and enabled individuals to take both medication abortion pills at home, and extended the use of medication abortion from 7 to 9 weeks of pregnancy. Another example is Nepal issuing interim guidelines for providers to use telemedicine for medical abortion and enabling pharmacists to dispense medical abortion pills. These are just a few examples. There's been countless other ones where the restrictions around things such as medication abortion and injectable contraceptives have been lifted, or where there's been greater access to telemedicine. And these are essential steps, and it's critical that they're maintained after the pandemic subsides, but they're also still inadequate for creating a truly enabling legal and policy environment around self-care. You can go on to the next slide, please. Indeed, in the context of sexual and reproductive health and rights, legal and policy barriers to self-care abound. And I'm going to use medication abortion as an example to demonstrate the myriad legal and policy barriers that individuals face in exercising self-care in the context of their sexual and reproductive health and rights. Admittedly, abortion is certainly one of the most restrictively regulated sexual and reproductive health services, but we see similar barriers to other services as well. And so I thought this was just a useful kind of overview of all of the different legal and policy barriers that one must overcome. So first, the person seeking abortion care must live in a country where abortion is broadly legal. Less than 40% of the global population live in countries that permit abortion on request, otherwise an individual must qualify under one of the limited legal grounds under which abortion is permitted. You can go on to the next slide, please. About 60% of the global population lives in countries where seeking abortion care, where abortion is heavily restricted, meaning that they are likely to face risking severe criminal penalties for ending a pregnancy unless they qualify under a limited ground, such as where there's a threat to the person's life or health, or if pregnancy results from rape. Indeed, 90 million women of reproductive age live in countries where abortion is illegal altogether. So for anybody in those countries, they would be, de facto or definitely violating the law by seeking out medication abortion because there's no legal grounds for abortion. Often these laws are broad enough that they also criminalize people helping others safely access abortion, including those providing information, medical abortion pills, or just supporting the person through the process. Additionally, medication abortion, we can go on to the next slide, please. You can hit the, additionally, medication abortion must be on the National Drug Registry. The person needs to have an eligible healthcare provider prescribe medication abortion and assess their eligibility. In some instances, this has to be a doctor. Often it has to be a doctor, but sometimes it can be a midwife and less often a pharmacist or a community health worker. By and large, countries' policies in this regard fail to adhere to World Health Organization guidelines, which supports a broad range of healthcare workers' ability to both assess eligibility for medication abortion and administer medication in the first trimester. Next, the person would need to fulfill all procedural requirements, such as waiting periods, ultrasounds, counseling, and any requirements about where they take the medication, the medical abortion pills, such as that the first pill must be taken in a medical facility or in the presence or under the supervision of a provider. And then beyond just the legal and policy restrictions, of course, we need to consider all the practical barriers that impact whether the person can access medication abortion. So this includes, do they have accurate information about medication abortion? Do they know where to access medication abortion pills? Can they cover the cost? Do they have access to transportation, etc.? And with self-care and in particular with sexual and reproductive health services, it can always be difficult to disentangle genuine lack of understanding or concern about the safety and effectiveness of certain healthcare interventions from the politics behind enabling greater access to these services. We can move on to the next slide, please. The WHO, though, and public health evidence clearly supports individuals' ability to self-assess eligibility for medication abortion, decide if and how to involve a healthcare provider, and to take medication abortion pills in the comfort of their own homes, among other things. We also know that self-care is a far more efficient use of resources without sacrificing safety or effectiveness. And yet, even in the face of a global pandemic, we saw relatively few of these barriers lifted, and only in a small handful of countries. So as we think about where we need to go and the opportunities for progress, I believe the human rights framework can provide us with an important lens to consider law and policy reform and the role of different actors around creating an enabling legal and policy environment for self-care. So self-care is grounded in a broad range of human rights, including the rights to health, which guarantees all individuals the right to accessible, acceptable, available, and good quality care, the right to equality and non-discrimination, and self-care interventions have the potential to make health services far more equitable and break down many of the barriers faced by marginalized groups. The right to information, which guarantees all individuals the right to seek, receive, and impart information on healthcare services, and recognizes government's obligation to guarantee individuals access to full and accurate information about sexual and reproductive health and rights. As mentioned, in many contexts, restrictive laws criminalize even the provision of accurate information about medical abortion and how to safely use medication to end pregnancy. The right to privacy and confidentiality, and just to recognize that self-care interventions have the potential to mitigate concerns about privacy and confidentiality that many individuals have about accessing sexual and reproductive health services in a formal setting. And the right to benefit from scientific progress, which guarantees access for all to the benefits of science without discrimination and in an environment that promotes the conservation, development, and diffusion of science and technology. And this can be interpreted to include access to many of the scientific developments that make self-care possible. Next slide, please. States are also obligated to respect, protect, and fulfill human rights. So this three-pronged approach, under the respect prong, states must refrain from interfering with or curtailing the enjoyment of human rights. And this includes overturning laws and policies that criminalize, prohibit, or otherwise prevent individuals from exercising their rights. But there's a need for law and policy to do more than just step out of the way from obstructing barriers. It also needs to affirmatively recognize and promote this kind of access and create accountability where individuals are unable to utilize self-care if they prefer. So the protect prong requires states to protect individuals and groups against human rights abuses, including by holding private actors accountable. And the fulfill prong requires states to take positive action to facilitate the enjoyment of basic human rights. And this is one point I want to emphasize in relation to self-care on sexual and reproductive health and rights and the role of law and policy. Because the law not only needs to be reformed to remove harmful and punitive measures prohibiting many forms of self-care, but it also needs to be reimagined to consider how self-care can be recognized as a right of all individuals and how governments can guarantee access to the information, supplies, and other resources for individuals to effectively exercise self-care. So we've now discussed the role of states and governments and their obligations as duty bearers. And I just want to say a quick note about the relationship between rights holders and duty bearers. Next slide, please. The term rights holder encompasses all individuals within any state who by nature of being a human being have the right to enjoy the full range of human rights. Duty bearers and rights holders have a reciprocal and mutually reinforcing relationship, wherein rights holders must be able to meaningfully participate in the formulation of laws and policies affecting them, have access to avenues to hold governments accountable when they're not living up to their human rights obligations, and be able to seek effective remedies when their rights are violated. As we discuss the challenges and opportunities that we are confronting in advancing legal and policy reform on self-care, I also just want to encourage us to think about the power that we have as rights holders and members of civil society to ensure that governments are living up to these obligations. I'm now going to hand the floor over to Dr. Austin Del Osta, Director of the Self-Care Academic Research Unit at the Imperial College London School of Public Health. Dr. Elosta is the director of the Self-Care Academic Research Unit, and he is also director and trustee of the International Self-Care Foundation and is a fellow of the International College of Person-Centered Medicine. His initial contribution to the self-care space was the publication of the Self-Care Matrix, which is a unifying framework for self-care. He also led the development of a pragmatic policy mapping tool that could be used at country level to assess implementation of the WHO Guidelines on self-care interventions for sexual and reproductive health and rights, which he's going to share more about with us today. Handing it over to you, Dr. Elosta.
Thank you, Katie, for the introductions and for a wonderful presentation. Thank you. So in this brief talk, I'm going to talk about the WHO Guideline on self-care interventions and how these guidelines can be a key driver for self-care policy and practice, how they can basically help us engage with policy reform, and how they can mobilize stakeholders internationally to promote the self-care movement. Next slide, please. So as you know, the guideline was published in June 2019. It included 24 recommendations across 4 categories, and they're listed here: improving antenatal, delivery, postpartum, and newborn care. That's 9 recommendations in this category. Providing high quality services for family planning and infertility services, 6 recommendations in this category. Eliminating unsafe abortion and combating STIs, including cervical cancer and other gynecological morbidities. Next slide, please. So if we just have a look at these recommendations, there's an abridged version here in the middle. There are 24 recommendations. 12 of these recommendations are really service focused. They don't need any specific SRHR products, whereas the other 12 need products like the MPA, condoms, pregnancy tests, and so on. And these are the 24 recommendations included 4 new recommendations emphasizing the use of self-administered injectable DMPA, oral contraceptive pills, ovulation protector kits, and self-sampling with HPV, syphilis, gonorrhea, chlamydia, and trichomonas. Next slide, please. So what we wanted to do is, because the recommendations were relatively new in 2019, we wanted to determine the extent that the 24 recommendations in the WHO Guideline on self-care interventions were being implemented in policy and practice. Now, there was no method for this, so we thought it would be good to pilot across 3 countries, Kenya, Nigeria, and Uganda, and really to feel our way around on how to conduct a policy landscape analysis that's relevant to this. To develop a pragmatic tool and methodology to assess implementation level. Also, we wanted to look at refining the approach to allow for replication in other country settings. And we wanted to see how we can use the findings to inform country-specific advocacy opportunities. Next slide, please. So as there was no precedent for this, we needed to develop a de novo method. And we did this using a 4-step approach. First thing we did was some desktop research to try to identify some policy documents, white papers, and publications that are relevant to the WHO guideline in the countries that we were going to explore. The second step was to engage with stakeholders to try to understand who the key players are, key opinion leaders, and to develop a stakeholder map. We ended up with a map of 291 contacts, 45 in Kenya, 51 in Nigeria, 35 in Uganda, and some other contacts from NGOs and elsewhere. We then needed to reach out to these contacts and collect information from either through e-survey or interviews. So we developed a tool, an online tool, a survey, which has 79 questions. You can say that's a lot of questions, which really asks stakeholders to respond about the extent that each of the recommendations were being implemented across the 4 categories. And in the end of that tool, we asked the respondent to let us know their contact details in case they're happy to be interviewed. And lastly, the 4th step was to interview some key stakeholders to understand their views on some of the barriers and drivers for implementation. If you press next, please. So this project really was spearheaded by the Self-Care Trailblazer Group. There was an interest from the Self-Care Trailblazer Group to actually do this. And we did this as a rapid exercise, just 4 months between December and March. So it wasn't a very long time. And we use a pragmatic approach to communicate results, which I can stream through now. And the main really point here was to identify key barriers and drivers to see how this tool can be improved in the future. Next step, please. So here's a view of some of the desktop research we did. This example is from the Uganda example. So we identified a number of documents, white papers, and policies, which would have control statements that we'd be really interested in for the policy mapping. Next step. Next slide, thank you. Then this is an example of the stakeholder map, a high-level view here, which included contact details and designations of various stakeholders and policymakers. What we didn't have, and we were very keen to get, were actually the contact details of people in the front line, for example, midwives and people who work in SRHR, because they would be very well placed to respond to questions about how the services are actually run. So we've had stakeholders that are in NGOs, Ministry of Health, some policymakers, we engage with pharmacists and public health practitioners and so on. Next slide, please. To collect data, and remember this wasn't done before, we needed to find a way to collect data that is somehow meaningful to us. We developed an online tool, and this is a snapshot of how it would look on a smartphone. It can also be accessed on a personal computer. And the idea is that respondents would use this tool to basically tell us about each of the questions we'd asked around the 24 recommendations. And they could select which country they are responding from, and we collected that semi-quantitative data for analysis. Next step, please. And this is an example of the interview group sheet we used. Now, the WHO guideline had 24 recommendations. There's no way we can talk about all of these. We were very keen to explore specifically implementation levels and barriers and drivers for the adoption of the new recommendations. So interviews lasted around an hour, and then we analyzed that data to just get a feel for how things are. Next slide, please. So the first thing we did was we tried to look at the availability of some of the SRHR products. These are things that people buy and use for self-care. And obviously we found that there are differences between countries, but we also found trends. There's very little availability, apparently, of self-sampling products, for example. There is, for example, limited availability of DMP subcutaneous in some countries. Next slide, please. We also took a different approach and began to see, to what extent are some of these SRHR products registered and permitted for use. How is the channel availability looking like, and what is the provision overall? This example here is from Kenya. It shows that there are some products that are routinely available, they are registered and permitted for use, with other products like misoprostol and misoprostol and self-administered DMPA are permitted under certain conditions, but not. But there can be progress made in that space moving forward. Channel availability is also, there's a lot of orange there. Orange means it's not fantastic. Green means it's good, and red means that there's a long way to go. So channel availability seemed to be relatively limited for a lot of the products, whereas provision as well, you can see here, is also different, and there is a lot of work that could be done to improve both the availability and the provision. And you would see that some of these products are new. They require new techniques, for example, the self-injection. Others are really requiring a review and streamlining of logistic and resupply chain. And so some items here are relevant to abortion, so therefore there's a legal framework that needs to be considered. Next slide, please. So this is a summary of our finding. In this table here, we try to show the 24 recommendations in the 4 categories, and our findings of the levels of implementation colored for each country. So green means that the recommendation is being implemented generally. Orange means that somewhat implemented, and red means that there's a long way to go before these recommendations are considered implemented. And the text in these colored boxes refer to control statements for each country that relate to each recommendation. So if we look at the Kenya example, for recommendation 4, advice on diet and lifestyle antacids for management of heartburn, Kenya had some policy documents to reflect that. You can see there's a lot more detail in Nigeria and Uganda, and we'll come to that in a minute. And that's because both Nigeria and Uganda were developing their own national guideline for self-care. And their guidelines echoed and included a lot of the recommendations included in the WHO, which is brilliant. And we'll be hearing from Dr. Moses later to get his view on how the national guideline were developed in Uganda. So this is an interesting finding because it's for the first time we had a rudimentary but high-level view of the extent that the recommendations are being implemented in each country, and also some of the control statements and policies and white papers that are relevant to this. Next slide, please. So at the very top here, you see the WHO self-care guideline. It's aspirational. It goes all the way from left to nearly all the way to the right. And for countries to do this, they need to, of course, have products and services that are available, that are permitted for use. The channels need to be available. The provision must be scaled up, and to embed self-care in practice, and then therefore to make it part of the culture. Now, this guideline will be met with natural barriers, lack of funding, for example, if there is poor awareness about the guidelines of self-care generally, or maybe it's one of the barriers is low health literacy levels in some people. So below that, we've got the, putting Kenya, Nigeria, and Uganda on this to just see how far have they come in terms of implementing the full guideline. You'll see there are slightly different levels of implementation, but they all have a number of drivers. And the key drivers here for Nigeria and Uganda are the national guidelines that are being developed and published soon. So each of these countries will have their barriers, of course, and there'll be context. When you break it down to the categories, we know that when you look at perinatal health, access, healthcare professional training, low online provision of services, and some cultural barriers and sensitivities may actually be a barrier to implementing the first category of the guideline. When it comes to family planning, there are issues with commodity supply, maybe some stigma. Some services are not youth-friendly, and a lot more can be done to enhance and promote task shifting for DMPA, for example. And of course, when you come to abortion, there's a lot of work that could be done in terms of looking at the legal status. We understand there's limited advocacy in this space, and there may be a lack of online tools for self-assessing eligibility for medical abortion. And when it comes to tackling STIs, there may be access and logistics issues, and currently some fragmented cervical cancer screening services, which could be enhanced to promote self-sampling for HPV and otherwise. Next slide, please. So a policy mapping exercise is really an opportunity to open the discussion for policy reform, to mobilize stakeholders, to ensure further implementation in the country. So we can use these findings to inform country-specific advocacy opportunities, to increase awareness in health literacy in people and in self-care stakeholders generally, and to work with these stakeholders to put policies into practice, and to work collaboratively to address regulatory issues and poor channel availability, and tackle logistical and resupply chain issues. Now, these will be known, of course, but it will be good to quantify that, and BSI and others are doing a lot of work on monitoring and evaluation frameworks to try to understand what is really happening and how improvements can be made. Of course, we can use these data to look at how we could review the criminal status of abortion. There are opportunities to optimize the provision of cervical cancer screening services, and these are fundamental for self-sampling, for HPV and otherwise. And a key role here is to promote task shifting, and that is really, it's about people skills. So it's actually, it will take many years for the culture to adopt and embed self-injection, for example, self-sampling, which may be common in the West, but less common in LMICs. Next slide, please. So you'd all know that there are new guidelines now published in June 21 by the WHO. And these guidelines are interesting because they, instead of 24 recommendations, they have now 37 recommendations in total. These are some of the new recommendations. And in the red, we have recommendations that are really looking at self-monitoring for NCDs like hypertension, blood coagulation, and self-monitoring glucose for type 2 diabetes and insulin. This is really exciting because although these recommendations still focus on SRHR, they're now beginning to introduce components that are relevant to non-communicable diseases. And these are modifiable risk factors that people can work with to promote and improve their health and well-being. Next slide, please. So that was a whistle-stop tour, but it shows that there's a lot of interest in self-care in recent years, and that interest has exploded. There are various self-care groups and stakeholders, and they're coming together. And there's concerted effort now to create a self-care movement. It's already here. And there's an increasing focus on measuring individual self-care capability and finding ways to embed good health-seeking self-care behaviors from a young age. So the guidelines then are a really important tool and a driver for the self-care movement. And there are many things that self-care stakeholders and policymakers can do to embed these guidelines nationally. And to open the discourse and to just basically support the self-care movement. Thank you very much. I think we're happy to take questions. I think I'll pass now to Christy, who would be moderating our session and our plenary. So over to you, Christy.
Thank you so much, Austin, for that excellent presentation. If you're just joining us, please, could you register your name and organization in the chat box? And also, if you have any question, please put it in the chat box also. We'll be taking it and directing it to the various speakers. I will pass over, sorry, my name is Christy Asala, and I'm the National Coordinator for White Ribbon Alliance Nigeria, and the strong advocate for self-care in Nigeria. I would pass on to Kati, who would introduce the plenary session. Over to you, Kati.
Great, thank you so much, Christy. So to kick off our plenary session, we're going to have two interventions from advocates working at the national level around legal and policy reform on self-care and on access to self-care interventions. I first want to introduce Moses Malumba, who is a lawyer with a special interest in international human rights, global health, and sexual and reproductive health and rights. He is the founder and executive director at the Center for Health, Human Rights, and Development, a leading advocacy group that is leading self-care advocacy in Uganda. He has been an African advisor to the HIV and the Law Commission and is a former board member of the Uganda National Drug Authority. Mr. Malumba has successfully been a principal and co-investigator on a number of research projects, including recently serving as a legal researcher on a scoping assessment of the global financing facility implementation in Uganda, and a study on developing the regulatory aspects for satellite-enhanced telemedicine and e-health for sub-Saharan Africa. I'm going to hand the floor over to you, Moses.
So much. It's such a pleasure joining this important conversation. So I will be speaking about the experience of the making of the national guidelines for self-care in Uganda. And I think the context, just like in many countries where low resources are, Uganda is overstretched already by resources. And as such, its health system cannot give the citizens that it actually needs sufficiently. A number of factors account for this. One is the low resources that the country has, but we also have a relatively high fertility rate, 5.4. The population growth is also relatively high, 3.1. So therefore, when you look at the number of people that the health system has to serve, they outweigh the skilled health professionals way above. But at the same time, Uganda is also very much having its legal and policy framework grounded in its colonial history, where we actually got laws and policies from the colonial times, and some of these still exist on our law books. So practices like self-care are not a part of those that are already captured in the laws. You can infer in some of the presently laws that are being made and policies, but there is no express provision that is made. So the making of the national guidelines on self-care was just one of those big steps that we witnessed as a country. So in terms of the process, Uganda adopted a two approach towards the making of the national guidelines. And the first one, very importantly, was ensuring that it establishes the group that it called the Technical Working Group on Self-Care, which is composed of various people, the experts, but also civil society, development partners, and all those that are interested in self-care at the country level. This was stage one. The whole purpose of for formation of this technical working group was to ensure that there is accelerated adoption of the adopted WHO global guideline, which had come in earlier in 2019. So around August 2020, Uganda started its own process. This process was headed by the Minister of Health. The Minister of Health has given leadership to making the guidelines. It hosts the meetings, and the Director of Curative Services chairs these meetings. It has periodic meetings that happen all the time, not to just discuss the guidelines themselves, but also discuss the practice that is existing and the number of emerging issues that touch on self-care at the country level. So there's been a lot of work that has been done by this particular group. So through the meetings that are convened, a technical working group, a number of technical working groups have been formed over time. These are aimed at ensuring that they focus on health systems preparedness, adaptability of the global guideline that WHO passed, but also the development of the standard operating procedures when it comes to self-care within the country level. So the task force and the groups are quite a number. There are 6. One of them is on quality of care. Another is monitoring, evaluation, and learning. There is one that focuses on behavior change. There is one that looks at human resources. Another focuses on medicines and supplies. And then the last one focuses on financing for self-care. So these have steered the work and have guided the process of making the national guidelines. So as part of this, a situation analysis was done. The Ministry of Health with other partners got a consultant who led the process of making a situational analysis. Now, the findings in the situation analysis are quite interesting because there was a finding that actually self-care is not just beginning with this particular process, because in 2016, there had been some work on the HIV self-test kit that was already happening as part of self-care. Then in 2017, there had been a lot of talk on self-injection and contraceptives. And indeed, the National Drug Authority had gone ahead to make some approvals on self-care and as far as self-injection is concerned. So also the management of post-abortion care in 2012 earlier on, when we looked at the sexual reproductive health policy guidelines that were developed, they had talked about self-management of post-abortion care, which was a big thing. And then in 2017, again, there had been some efforts around self-collection of samples that are taken to laboratories for further testing. And then HPV was also a big issue that we had witnessed in 2017. So overall, self-care initiatives were happening, but they were not documented, and there was no one single policy that was important for ensuring that self-care is actually achieved. When you look at the final guidelines and how they shaped up, they are also quite interesting because they adopt a number of processes and WHO recommendations that are made. But most importantly, they clearly indicate that they are grounded in self-evidence-based recommendation, which was one of the key things under the WHO recommendations. The good practice statements are adopted quite heavily, and then the focus on making sure that the guidelines are a living document and are living guidelines, which keep changing with the context that we keep seeing. So this situation analysis enabled the formulation of the first drafts of the guidelines. These guidelines were later taken through the Ministry of Health processes and fully approved through the various channels that the Ministry of Health adopts. Now, as part of this, our organization joined in as an advocacy institution to lead the national advocacy around the national guidelines. We did not just want to do advocacy, but also provide technical support in terms of human rights-based approaches and legal analysis towards adoption of self-care. As part of this process, we started by doing a stakeholder mapping and analysis of the various stakeholders. And it was very interesting to see that there are quite a number of efforts and a number of stakeholders involved in a process like this, but some of these were disjointed and not coming together sufficiently. It was also one of the things that we realized that several other stakeholders were working on self-care related things, like those working on HIV/AIDS, but still they had not been brought together. This stakeholder analysis has helped us as an advocacy group to understand who we need to work with and where we need to head next. The other important process was our own legal analysis to see where the guidelines are actually situated. In most cases, if you do not give a legal value of the national guidelines and ground them in a particular policy or particular legislation, eventually it becomes a problem. So we did a legal review of the guidelines to actually find out how they are fitting within the existing legal framework. Now, Uganda's legal framework is quite interesting. We have adopted and ratified a number of international instruments, but we've made very many reservations. And some of these reservations will affect the implementation of the guidelines. We also have regional laws and regional policies at the East African level, but also at the African level. While these are very important, they are not as progressive as one would want to see them, but they are enabling in one way or another. They become a piece of an advocacy grounding where to start from. Then it's also interesting that Uganda has had a number of policies, so many policies that touch on self-care in very many areas. And one would want to actually see how all of these speak to each other. But one notes that the policies are moving faster than the laws. Very many of our laws remain very old and archaic, and the policies are much younger than the laws. We also had the situation where the policies are more enabling towards self-care, but the laws are not that enabling. And because you cannot use the policies to enforce things, it becomes a bit complicated when the laws are not moving as fast. The national constitution is not expressed on self-care, for instance, but it has very interesting provisions on access to healthcare and government creating obligation itself to ensure that citizens access care, and also giving specific categories of people care and their own authority within their own right to take care of their own health, like the women under Article 33, the children, persons with disabilities. All these are categories that are recognized in the Constitution and as entitled to health care, and we could use the constitutional provisions in an enabling way. Then, as I indicated, part of the legislation that we have at the country level that we need to battle with is very old legislation. Our Penal Code Act is still a colonial Penal Code Act. It still has criminal offenses for things like abortion. We have the National Drug Authority Act, which is a 1993 act, fairly old now, when you talk about self-care, and we will need to revisit it. But we also have interesting legislations, especially on IT, electronic transactions legislation, which is very key for self-care, and data protection legislation. The other pieces of legislation are on other sectors like HIV/AIDS, traditional and complementary medicines. These are all important pieces of legislation with important provisions that one can read into the self-care provisions that is important. So as a way of summarizing, I think we have prepared, we have now adopted the self-care guidelines at the country level. I think the stage we are getting into now is the implementation stage of these particular guidelines. So the adoption of the standard operating procedures is very, very important as we move ahead, but also situating these guidelines within the existing legal frameworks in a more progressive way is going to be super relevant. There is a plan for a baseline that will be done to do some testing on how these guidelines play out things within the districts. One district has been proposed, and then they're also trying to situate a refugee setting as one of the situations where the guidelines can be tested. And we think that this is one of the things that needs to happen. We know that the School of Public Health at Makerere is also working on measuring tools. And these are tools that will be able to enable us understand what success actually means for the implementation of the guidelines. And it's all part of the implementation process. So we'll be looking forward to seeing how Uganda acts as one of those first countries that are implementing the national guidelines. For now, I'll stop there and get ready for any questions. Thank you very much.
Thank you so much. And I'm now going to hand the floor over to Dr. Lucia Berro Pizarosa, who's a feminist activist lawyer with more than 10 years of experience working on abortion. Lucia has an LLB from Universidad de la República, an LLM from the University of Oxford, and a PhD in international law from the University of Groningen in the Netherlands. She has worked as a consultant on abortion matters for IPAS, RSFU, and Inroads, among others. And she is currently an associate at the O'Neill Institute for National and Global Health at the University of Georgetown. She also works for Women Help Women, coordinating the legal support network of MAMA, which is mobilizing activists around medical abortion. Handing it over to you, Lucia.
Thank you so much, Katie. And well, I want to start by saying thank you so much to the presenters that presented just before myself. It's a real pleasure. I feel like we're all like buzzing with ideas, and it's a very inspiring space to be. So thank you so much for the invitation. As Katie was saying, my name is Lucia, and I coordinate the Mama Legal Support Network, and I'm also a researcher at the University of Georgetown. But my remarks today and the things that I wanted to share with you have to do with my academic work, of course, but mostly have to do with my activist work, and in particular in the field of self-managed abortion. And what I will share here with you is part of work that I have been doing with my colleague, Dr. Rishitananda Giri, she's based at the London School of Economics. And we have been working a lot in like unpacking what does self-care means for abortion, and how does those self-care trajectories interact with the legal and policy frameworks, right? So while I agree that self-care has an undeniable transformative potential in the field of abortion and other matters of health, I think it is very important to be clear about what exactly we're talking about, right? Because terms like self-care, self-management, self-use, self-administration are all very similar, and they are certainly related, but they are very distinct. And why do I think it's important to make a difference? Because they certainly have different levels of risk that has to do with social stigma, but risk that has to do with criminalization, right? So can we move to the next slide? Thank you. So in general, I like to use this definition when I talk about self-care and when I talk about self-managed abortion. I use a definition proposed by Susan Yano, Kinga Jelinska, and Joanna Erdman. And I think because it encompasses many things. The fact that self-care in abortion and in self-managed abortion has to do with actors, has to do with spaces, and has to do with actions that are all subject to the regulation of the law, right? So they are all somehow regulated in one way or another, sometimes by criminal law, sometimes by health law, but nonetheless, those are like policy and legal barriers, hurdles that people have to jump to access, so to be able to self-manage an abortion safely, not from only a public health point of view, but also from a legal point of view, right? And can we go to the next slide, please? Thank you. And the first point that I wanted to make is this complexity, right? When we talk about self-care and we talk about the legal and policy barriers and matters that people need to like jump in order to safely access, we are talking about abortion laws that are regulating that process for sure, but also we talk about a lot of laws that go way beyond that, right? So it also encompasses a series of regulations that has to do with import and export of drugs, that have to do with the professional conduct, such as the licensing to provide to purchase and sell drugs, etc., etc. So my question is, and I want to bring some examples to the table, is like, what are we talking about when we're talking about self-care, right? Like, the key question for me is like, are we promoting self-care within the restrictive, medicalizing and over-regulating framework of the current laws and policies, or are we really proposing a self-care paradigm model that is way more emancipatory, that is different from the existing laws? Because that will mean that promoting self-care in matters of abortion has to do with a radical change in terms of how abortion is regulated and how other matters that have to do with self-care in abortion are regulated in national jurisdictions. So I wanted to share the trajectory, right? And consequently, right, those restrictions that I've been mentioning that have to do with the provision of information of abortion, that have to do with who is legitimized within a legal system to provide information on abortion. Can a hotline worker do it in that spirit of task sharing, right? So in the issues that criminalization is a very real threat. And so, for example, in the United States and Northern Ireland, women have been prosecuted for searching online or ordering abortion pills for themselves or for their daughters, right? And the charges have included providing abortion without a medical license, dispensing drugs without a pharmaceutical license, assault even, right? So the risks of some of the aspects of accessing self-care and abortion are very, very, very real and very, very burdensome. And can we move to the next slide, please? Thank you. So in Uruguay, for example, like in 2012, we adopted a very, and I am from Uruguay, by the way. So we adopted a very fairly liberal abortion law. And since then, 98% of abortions have happened in the formal healthcare system and happen with a combination of mifepristone and misoprostol, right? But people get prescribed the drugs and they'll self-administer the drugs and manage the abortion process at home and only go to the formal healthcare system if complications arise or for a post-abortion care checkup. However, since then, since 2012, a number of people have been prosecuted for illegally selling, purchasing, using, and supporting the use of misoprostol, right? As the drug is now only available within the formal healthcare system, not sold in pharmacies under any indication, and any abortion that happen outside of the channels prescribed by the law is criminalized. So I think this showcases a little bit what Katie was mentioning, right? That there's an existing legal and policy framework barriers that are related to these three components that I mentioned before, the actors, the spaces, and the actions, right? Such as in the case of Uruguay, placing unduly burdensome requirements to access these essential medicines that are recognized as such by the WHO, and like the requirement of close supervision by medical professionals. That is a requirement that is no longer needed by the WHO. So it's also bringing that so-called liberal regulations on abortion also in line with what we want and we envisage self-care to be, right? And on the same vein, like as countries reform the regulations in the context of COVID-19 and increasingly adopt models of telemedicine that are similar to those that are used by activists and frameworks for decades, I think it's very important that we also keep this in mind, right? And this brings me to a little bit of if we can move to the next slide. Yes, perfect, thank you. So like what I'm trying to say here is like we have moved somewhat in some countries, France, South Africa, and many others, towards a model is somewhat flexibilizing in-person requirements, and it has incorporating telemedicine, right? But this model is not new. This model has been used by activists and feminist networks for a long time, right? And let's think, for example, in the UK, people are allowed to manage their own abortions. Those requiring abortion can access a telemedicine consultation with a registered medical professional and receive the MA pills at home. And how is this process different from what feminist networks and Hotline have done successfully during years? If we think about the protocols of use, how to use the medication, if we think about the active involvement of the pregnant person in the process, if we think about the drugs themselves, none of these are fundamentally different. However, the legal risk and the risk of criminalization is radically different, because one happens within the institutionalized healthcare system and the other one happens outside, right? And this is particularly stark, this like differentiation between one model and the other is particularly stark when the quality of care is on par with formal healthcare system. And it has been like in the end, the work of activist network have been the one transforming the discourse and pushing the science between what now we know as a telemedicine model. So I want to pick this up from a fantastic activist, Renee Bracey-Sherman, and she says like the self-managing abortion and self-care in abortion is not a new matter. People have been terminating their pregnancies on their own for a long time. What has changed is now with the advent of abortion medicines, the safety of that self-management has increased radically. However, the criminalization still remain, right? So while self-care for medical abortion is very safe from a public health perspective, it is hardly safe from a legal perspective, right? As the policy and laws have not evolved to embrace the evidence that we know and we are very familiar with, and the human rights standards that already exist and have been evolving in this direction, as Katie was mentioning before, right? And the second important consideration, and I want to close here, is that SMA and self-care have also a collective connection, a collective nature to it. So while empowering the individual and working on the self part of self-care, we must not forget that the part of the care or the part of the management, the part of the trajectory is equally important. Because indeed, self-managed abortion, rather than being a solely individual act, pregnant people's self-care trajectories are shaped and influenced by a myriad of actors along different points of the journey, right? And I'm talking about Hotline counselors, that I see some of my colleagues here doing fantastic work. I'm talking about community providers. I'm talking about feminist networks that source medications in very restrictive context. So these actors that function locally, nationally, and transnationally enable this self-care and provide different types of support. However, as I was mentioning before, these actors are made vulnerable and exposed to social and legal risk because of the work around self-managed abortion. They experience direct criminalization, risk of imprisonment, because of contraventions that have to do with abortion laws, but as I said before, because of contraventions that have to do with laws that are outside abortion laws, and risking their livelihoods, their freedom, etc., etc. Can we move to the next slide, please? Thank you. And this, for example, as I was saying, like the risk that these actors face is exemplified, for example, in the situation in the Rwandan context, in which, for example, last year in 2020, it wasn't the first time that the president exercised this prerogative of mercy, but he exercised it again, pardoning 50 young women that have been convicted for abortion, right? But 9 people, among them mothers, among them activists, among them friends, partners, etc., who aided in accessing this abortion outside the process prescribed, the law, will serve their full sentences. And in some cases, punish even more harshly than the person self-managing the abortions themselves, right? So these laws that criminalize assistance, basically, and we see this happening in many, even in the newly reformed abortion laws, what they are doing is undermining long-standing practices of feminist solidarity, right, that have existed across the world. And so I just wanted to close by saying that the self-care and the self-managed abortion landscape, as we know, it wouldn't exist without the work of these feminist organization networks. And any attempt of regulation must account for their work, right? And as just to conclude, I feel like to truly realize the promise of self-care, right, we really need to focus on lifting those legal and policy restrictions, including those that are based on over-medicalizing or over-regulating a fairly simple and a fairly safe process. So I'm curious to hear your thoughts about this, but I mean, I'm very convinced that we need to be very vigilant of any law reforms that have to do with abortion that attempt to regulate self-managed abortion by medicalizing it or by incorporating a series of unnecessarily burdensome steps that create vulnerability for the person self-caring an abortion and for the persons that support that safe self-management. So, I mean, I'm very curious to hear your thoughts. I've been working on this for a long time. And as I said before, like I'm coordinating a group of lawyers that are working in the African context with groups that support safe self-management, identifying and mapping the legal risks and the policies and laws that exist across the continent. So I will be very, very keen to hear your thoughts about what I just said, and yeah, excited for the questions and the conversations to come. Thank you very much.
Thank you so much, Dr. Lucia, for that excellent presentation. And thank you also to all our speakers so far. But we'll take a pause here, and we want to hear from you. What questions, comments, and reflections on the presentations we've had so far. You can just come off mute and let's take your questions or comments. All right, anyone? Okay, so while you can also drop your questions on the chat box, and I think I have a question here. This is directed to Katsi. So regarding duty barriers and rights holders, what does this mean? I mean, in real life and real experience, what does this really mean?
Thank you so much, Christy. And I actually would kick that back over to those on the line. It would be great to hear from others about the challenges and opportunities they see in creating accountability for states' obligations in relation to self-care, and also reflections of the presentations that we've heard and what resonates to you all around some of the good practices and how some of these can be replicated in other contexts.
Katie, if I may, just briefly on this. So, you know, we're all we all have rights, and we're all duty bearers and rights holders. So, is there? I just wonder, maybe back. I wonder what others feel. Is there supposed to be leadership and mechanisms to actually ensure that there are groups that are responsible for that? Should there be frameworks to illustrate specifically what these duties are and who should be acting on them in each country? Because we are all stakeholders of self-care, we are all duty bearers and rights holders. Or do you think there are or should be more formal groups and mechanisms to actually articulate that in each country?
I think I did see a hand up. Martha, did I see your hand up? And do you want to just jump off mute? I'm not sure if we have to unmute Martha on the top side.
No.
Oh, go ahead.
Yes, hi, thank you very much. It wasn't, I've now had a question back a few points ago, so I don't want to interrupt the flow here, but just quick couple of points. Thank you all. The presentations were all excellent. I've been writing notes in the chat here, so I have questions about each, which I won't do now. I'll take up Austin's last question right here, his point about, we use the term rights holders and duty bearers a lot, and it's all of us in some way, shape, or form can be both. But I do think this notion of kind of concretizing that a bit more in countries could be useful, because I think it's a term those two terms get used a lot, and it might be a helpful thing in thinking about mapping. And one other point I just would like to say about Austin's presentation, excellent. I thought that overall process you used was very helpful, and I can imagine some fine tuning and adapting of that could be a useful step forward. Yeah, and one other point, sorry, and then I'll stop. And that was to Moses's point, which I thought was really important about there are many self-care policies moving along quickly, but they're not necessarily in alignment with the legal and the laws. And so how do you streamline those processes? And then of course, the last point is just about language and definitions and conceptualizations. I think we heard that in the abortion space particularly. I'll stop there. I've written stuff in the chat.
Thank you so much. I think we have a few more minutes. Are there other thoughts or comments or reflections from the presentation so far?
It's Aisata Asal from PRV. Just about this point about duty bearer and what just Martha said, or Austin or you. Austin, you said we are all duty bearers or right holders. And actually something that is clear to everybody is that if you take contributive social protection, it means your health insurance and the role of your government and the role of your employers. These are the natural duty bearers and right holders we know, because these are the three called all over the world social partners. Now, if we go to non-contributive, and you talked about poor and vulnerable populations that is not contributing for social protection, nobody is talking about them about right holders or any social partners. And this is something that is appearing in self-care, because they are the social partners that from their systems that really can support the government and other parts to build this system. But because they are not contributing, these terms, and thank you, Kathleen, and you know that I really appreciate the fact you brought that point, because it is very rare that people not being able to contribute to their social protection are called right holders at the same level of decision like duty bearers that are government. So my question would be, maybe it is time to call them also social partners the same way we are called because we are paying tax or because we are employees. It's not a question of being able of paying something. It's a question of human rights, actually. So thank you.
Thank you so much for that comment. Yeah, I think Christy Cade is raising up her hand.
Thanks, Christy. Yes, I just have a question for Dr. Austin. And apologies, I did come in at the tail end of your presentation, so I was in another meeting. But I noticed within the self-care space, there's such a focus on interventions. And a lot of the policy mapping to this point in time does relate to interventions. And I'm just curious if you see a role for policy in helping to kind of accelerate or advance some of the softer pieces of self-care, so to speak, in terms of helping to accelerate some of the behavioral paradigms that really need to shift in order to really create an enabling environment for self-care that isn't so intervention focused. And just your thoughts and reactions on that would be really valuable.
Thank you. I'm happy to address that, Kirsty. So absolutely, I think, how do we embed good health-seeking self-care behaviors from a young age? So self-care is very intimately related to behavior change. And, people are right when they say, show us the evidence for, evidence-based self-care interventions. And there aren't actually many. The WHO guideline is interesting because it focuses on SRHR, and there's evidence there. And that was probably a very good start, because if you immediately go into self-care for NCDs, the lifestyle diseases that are reaching epidemic proportions, then it'll be very difficult to compile a guideline. It'll be very, very long and very big. So I think embedding health literacy in school curriculum, teaching children from a young age how to embed good self-care behaviors. We often look at the 7 pillars of self-care, which is something we haven't discussed, because self-care can mean anything to people. Even the WHO has 5 definitions. In fact, in academic papers, you can find up to 139 definitions. So one way to conceptualize it is the 7 pillars of self-care framework: health literacy, mental well-being, physical activity, healthy eating, risk avoidance, good hygiene practices, and the rational use of products and services, including over-the-counter medicines, parks, green spaces. So when you approach self-care from this perspective, you would then look less at the evidence base for interventions and more about lifestyle. And that is the remit of lifestyle medicine and behavior change. So I know that PSI and others are doing a lot of work now to try to see, what can governments and people do, society, culture, communities do to develop a movement of self-care. It's the oldest type of care, and it's now become very interesting again because there's a lot of attention on self-care. But to go back to your question, I think for countries to develop a self-care journey, thinking ahead in 2030, how would 2030 look like? What can countries and people do now to enable people to live longer, healthier lives, to prevent, delay, or alter the disease course? I'm going around the bend here, but yes, self-care is very encompassing, it's very cross-cutting. So we work with the WHO guideline because they're one of the very few examples that actually in fact, they champion the self-care movement. So I hope that answered the question, Kirsty. But I think education, health literacy, this isn't something that could be done in one, this is going to take a generation for people to become very self-care ready, I think. And the role of digital and technology is going to be key here in remote monitoring, self-monitoring. But back to duty and responsibility, it also, rights and responsibilities. So should someone choose not to self-care, and even though, for example, they may know that excess alcohol or excess smoking is bad for them, what are the consequences there? So is the state going to tell us what we can and cannot do? Because there is evidence that we should self-care more for this. So I just wanted to unpack the discussion, and that was my question to Katie and others, that when you say duty and rights bearers, will there be a policing of that? That's a contemporary issue currently, but broad discussion here. So I hope I answered the question, Kirsty.
Yeah, no, thanks. It's great. Really interesting observations. I think it's something we're all grappling with a little bit. So that's partly why I wanted to ask and get your perspective. Thank you.
Thank you, Christy. So there are a few comments.
If I can, just briefly to push back a little bit on Austin's last point about the role of the government and the idea of kind of policing self-care. I think really the idea from the human rights framework is that we're looking at an enabling legal and policy environment. So, we're looking at not just the law stepping out of the way to remove all of these harmful restrictions and these harmful barriers, but actually thinking about how do we proactively make sure people have a right to access, the medications and the services that they might need to actually access or actually practice self-care. So, going back to, using the SRHR context, there might be people who are interested in injectable contraceptives, but the law doesn't allow them to, access injectables and self-care, use injectables as a form of self-care at home. And they require them to be administered by a healthcare provider, despite public health evidence to the contrary. So I think what we're really talking about is something that's a little bit different, right? We're talking about maybe not taking such a big step back of looking at kind of every single pillar, facet of self-care and what the role of the law or policy is, but looking at where there really is a proactive legal and policy framework that can not just remove these barriers, but actually enable access by making sure that these aren't just things that are available in theory because there's no prohibitions on them, but that there's actually, you know, an affirmative obligation on governments to make sure, for example, that there aren't contraceptive stockouts, that people have access to the medications they might need or the testing they might need to practice self-care as well.
Absolutely, Kathy. Thank you for that. And yeah, removing barrier is one thing, and creating access, you know, for people that actually need those products, it's you know, something else. So we have some comments in the chat box. I will just read. There's a comment from Patience Bull. Hello all, great presentations. Is there a paper published from the study? I see a lot of things I can refer to support my own research, but will need references. So I guess Austin can also help.
To respond to that. So I think there's certainly some studies that we could share out for folks, but we've also been, as the coordinators for this session, have been talking about if there is some sort of an output from this that we want to compile around legal and policy barriers and self-care, whether it's a resource or reflections from this session. And so sort of a combination of both. There's materials out there that we can certainly share, but that we're also considering if there's a concrete output from this that we could be working to kind of curate or create.
Thank you. If I may, this doesn't relate specifically to this, but we are preparing a manuscript to report the findings of the policy mapping, and I'm going to include in the chat a link to the BSI website, which has the fuller slide deck of what I presented. It somehow relates to this topic because it is really the role of leadership, ministers of health, self-care networks and self-care groups and guidelines that are being developed now to promote the self-care agenda. So, but yes, we will be publishing a paper in the next while, and we can maybe circulate that via PSI. Thank you.
All right, thank you, Austin. We have 2 comments from Sheila. Sheila, do you want to come off mute to talk about this?
Hi, everyone. Thank you, Christy. My comments were just around the issue of policy and just acknowledging, I think maybe Katie mentioned it, that it's not just about working on the policy, but that it would have to be accompanied by a lot of groundwork on destigmatizing some of these aspects, and especially in some of the controversial ones, things like safe abortion and maybe contraception uptake, mostly because we found that sometimes there are laws, but then they're not implemented, or they're kind of overlooked because there's a lot of stigma within the community. And then my other point was around the fact that I think we would probably need to think through or continue our work on policy, seeking out or developing policies that are evidence-based. And again, responding to something that someone mentioned around research and the need to have that research information shared so that it's accessible and can help all of us, kind of like a hub of sorts, so that we can all have a pool to discuss from when we're doing our policy development. Thank you.
Thank you so much, Sheila. And yes, valid points there. We all, I mean, we talked a lot in this, even in this series, about the absolute need for us to have data and also have resources to share. I think there is one more comment from Dr. Leila. She also had made a comment earlier. Dr. Leila, do you want to come off mute?
Yes, thanks so much for allowing me to just ask a sort of more pointed question, since we're in SRH policy. What are some of the key barriers that you've faced when dealing with trying to expand an enabling policy framework for self-care from those who've done this in various countries? That would be really helpful. I enjoyed listening to the 3 country presentations from Africa, and if any of them would like to share an example, it would really be helpful. Thanks.
All right, thank you. Dr. Moses, do you want to take on this one?
Yeah, let me speak to that. I think the biggest challenge is that guidelines must work within the existing legal frameworks. So where the legal framework is limiting, you cannot have a more expressive guideline, no matter how you would want it to be. So the challenge of the already existing laws and policies that are not expansive enough make it very difficult for a national process to adopt a very good progressive guideline. So I think it takes work that is just beyond adapting the guideline at the national level. You have to undertake serious legal reforms and serious legal advocacy to make sure that you open up spaces that are closed. In areas like Uganda, just a mere mention of the word abortion sometimes makes it very difficult. And I was looking at the process of making the guidelines here and putting the sections on even safe abortion or post-abortion care. It is heavily contested, heavily discussed. And sometimes you can't go to the parameters that you would want to go. And why that is the case is, again, the framework that is existing that we need to work with. And then lastly, for me, is that even when you surmount and make the guideline and put it in place, its own implementation is very much inhibited by the existing social norms and social beliefs. So there is both the process, but also once the product is out and how you let it out becomes important. And because of, again, limited expertise in some areas, it becomes very, very complicated to make things happen. Thanks.
Thank you so much, Dr. Moses. I hope that answers your question, Dr. Leda. All right, so I will be handing over to our next speaker, Aissata Fall. Aissata Fall is a social protection senior advisor. She joined PRB in early 2020, and she has more than 25 years of experience in West and Central Africa, upholding the rights of the most vulnerable residents and minorities through a range of areas, including local development, democracy, decentralization, and access to basic social services. Over to you, Aissata.
Merci beaucoup, Christine. Je pense que ma caméra est allumée. J'espère que vous m'entendez. Donc, je suis Aissata Fall, conseillère régionale Afrique de l'Ouest et du Centre à PRB. Je suis basée à Dakar. PRB est une ONG internationale qui intervient dans les domaines de la démographie, santé des populations, planification familiale et santé maternelle et reproductive. Et nous travaillons particulièrement sur la communication des résultats de recherche pour informer le dialogue politique et pour l'élaboration des politiques basées sur des données probantes. Et donc, je suis heureuse d'avoir aujourd'hui l'opportunité de partager avec vous quelques perspectives sur l'importance de la collaboration intersectorielle pour réussir l'auto-soin. Je me permets de remercier particulièrement Monsieur le ministre de la Santé du Burkina Faso, qui est avec nous et qui, par sa présence, marque l'importance de réunir les différentes parties prenantes autour d'une même table, même si cela, au mois d'août, avait l'air d'être un peu difficile. Donc, merci beaucoup. Next slide, please. Next slide. Merci. Donc, la définition d'auto-soin basée sur la capacité des individus ou des communautés à gérer leur santé implique de reconnaître que, quels que soient les facteurs et les processus qui peuvent déterminer le comportement, quelle que soit l'efficacité de l'auto-soin et quelle que soit la manière dont il s'articule avec les soins professionnels, c'est l'individu qui agit ou n'agit pas pour gérer sa santé. Donc, comme on l'a entendu dans les conversations et dans les présentes présentations, quand on parle d'auto-soin, on parle de droits humains et on parle de redevabilité. La réalisation du droit à la santé de tous repose fondamentalement sur la prise en considération de l'équité, des droits humains, du genre, des déterminants sociaux de la santé. Et la promotion et la protection des droits de l'homme dans le contexte de l'auto-soin repose, elle, fondamentalement sur l'accès à l'information par les utilisateurs, leur autonomie, leur capacité à prendre des décisions concernant leur propre vie et leur propre santé. Et ceci est particulièrement pertinent pour les populations vulnérables, marginalisées et socio-économiquement défavorisées, qui peuvent ne pas être conscientes de leur droit à la santé, ni être en mesure d'accéder aux services dont elles ont besoin, alors qu'elles ont les résultats de santé les plus faibles. Parallèlement, les États ont pour obligation de respecter et de protéger ces droits. Les interventions d'auto-soins se situent souvent dans le continuum entre le système de santé et l'utilisateur. Donc, c'est une position qui demande à être soutenue par un environnement sûr et favorable, et particulièrement au plan politique et juridique. Et je souhaiterais maintenant resituer un peu ces engagements et ces aspects de droit dans le contexte des engagements des États pour des systèmes de santé durables. Next slide, please. Next slide. Merci. En 2018, les États membres se sont engagés à renouveler et à mettre en œuvre les soins de santé primaires comme élément central d'un système de santé durable et favorisant la réalisation de la couverture sanitaire universelle, l'atteinte des objectifs de développement durable liés à la santé et l'atteinte de la sécurité sanitaire. Les soins de santé primaire représentent le moyen le plus inclusif, le plus équitable, le plus économique et le plus efficace d'améliorer la santé des populations et le bien-être social. Et la contribution de l'auto-soin au progrès des soins de santé primaire est reconnue de manière croissante, et parce que ça répond à l'appel à mobilisation, la déclaration d'Astana sur les soins de santé primaire, qui réclame de répondre aux besoins des personnes par des services de santé complets et intégrés tout au long de la vie, en privilégiant les soins de santé primaire et les fonctions essentielles de santé publique, mais aussi d'aborder systématiquement des déterminants plus larges de la santé à travers des politiques et des actions basées sur des données probantes dans tous les secteurs. Et enfin, cette déclaration appelle à donner les moyens aux individus, familles et communautés d'optimiser leur santé, et notamment en les considérant comme des partenaires des services de santé, des partenaires des services sociaux, tout en étant des utilisateurs de l'auto-soin. Donc ici, la notion de cycle de vie est essentielle. Tous les individus sont susceptibles de voir leur état de santé se détériorer ou susceptibles de devenir dépendants au cours de leur vie. Le risque de la vulnérabilité existe pour tous, et la seule parade est de construire sa résilience grâce à un soutien et grâce à des soins appropriés. Ce qui veut dire qu'un environnement propice à l'auto-efficacité et à la résilience doit être un objectif important du système de santé. Donc, une approche centrée sur le cycle de vie renforce la capacité des individus à accéder aux bonnes interventions, au bon moment, tout au long de leur vie. Elle place l'état de santé actuel des personnes dans leur contexte de vie actuel et met en évidence les diversités au sein et entre les populations, et reconnaît alors les différentes perspectives des individus, des familles ou des communautés. Donc, de fait, une approche par le cycle de vie entraîne une approche centrée sur la personne, qui considère les utilisateurs de soins de santé autant comme des participants que comme des bénéficiaires de systèmes de santé fiables qui répondent à leurs besoins et à leurs préférences. Cette approche qui est organisée autour des besoins en santé et des attentes des personnes, plutôt qu'autour des maladies, améliore les performances des systèmes de santé sur plusieurs aspects qui vont du coup à l'équité d'utilisation, en passant par l'amélioration de la qualité des prestations ou encore la satisfaction des utilisateurs. Next slide, please. Next. Les lignes directrices de l'OMS disent, et je vais lire textuellement, que les interventions d'auto-soins sont une opportunité pour accroître la participation active des individus à leur propre santé, à condition d'être mises en œuvre dans un environnement propice, c'est-à-dire qui facilite l'accès et le recours aux produits et aux interventions améliorant la santé et le bien-être des populations vulnérables et marginalisées. Atteindre les cibles des ODD liés à l'auto-soin demande alors de considérer systématiquement tous les aspects de l'auto-soin, aussi bien que l'environnement élargi dans lequel l'auto-soin est mis en œuvre. Créer et garantir un environnement propice pour offrir l'auto-soin de manière sûre et appropriée doit être le point de départ clé de toute stratégie visant l'introduction ou le passage à l'échelle de ces interventions. Et vous voyez sur le schéma, sur le slide, les différents facteurs qui vont déterminer justement l'accès des personnes à l'auto-soin et l'utilisation des services de santé et le résultat de santé. La création et le maintien d'un environnement propice à l'auto-soin doivent être informés par le profil des utilisateurs potentiels en premier lieu, ensuite par les services proposés et enfin par l'environnement légal et politique, tout en considérant les supports et les obstacles structurels. Next slide, please. Next. Donc, comme vous voyez sur le schéma, plusieurs facteurs déterminant l'accès et l'utilisation des services de santé par les individus et déterminant aussi leurs résultats en matière de santé ne dépendent pas uniquement du ministère de la Santé. Par exemple, l'accès à la justice, l'autonomisation économique, la protection contre les violences ou encore l'accès à l'information et l'éducation font partie d'une manière générale des agendas de protection sociale de pratiquement tous les pays d'Afrique francophone, d'Afrique de l'Ouest, avec des responsabilités partagées entre les missions de plusieurs ministères sectoriels qui mettent en synergie leurs différentes compétences pour atteindre les objectifs de politique sociale au sein de cadres de concertation transversaux. Donc une collaboration et un dialogue intersectoriel au sein des gouvernements et entre les différents niveaux de responsabilité déconcentrés et décentralisés sont indispensables pour que ces facteurs se traduisent en actions soutenant efficacement l'accès et l'utilisation des services de santé par les utilisateurs. Mais la collaboration et le dialogue politique incluant l'ensemble des parties prenantes est tout aussi indispensable. Next slide, please. Donc, pourquoi est-ce que je vous parle de protection sociale dans le contexte de l'auto-soin? La protection sociale, c'est un droit fondamental de l'homme qui garantit à chaque individu une protection par la société et par l'État. C'est un ensemble de mesures qui visent à réduire la vulnérabilité des populations au risque et à l'impact des chocs, à éviter l'emploi de stratégies d'adaptation néfastes en cas de problèmes mettant en danger les minimums de vie, et à garantir des niveaux minima de dignité humaine. La protection sociale est mise en œuvre par des instruments transversaux axés sur la demande sociale des services qui, quand ils sont associés à l'offre de services des politiques sectorielles, composent les politiques sociales d'un pays. Donc, la protection sociale n'est qu'un mécanisme, en fait. On parle d'un secteur de la protection sociale, mais qui va ne faire que relier la demande sociale avec les différentes offres de services existantes. Depuis 2008, les filets sociaux sont un élément central des stratégies de développement des pays d'Afrique pour lutter contre la pauvreté extrême et aider les ménages vulnérables à mieux faire face aux chocs sans recourir à la vente de leurs outils de production et sans compromettre, par exemple, leur santé ou l'éducation de leurs enfants en les aidant à accéder aux services sociaux de base. Et en fait, dû à la spécificité de nos contextes et à l'absence de modèles extérieurs adaptés, nos pays en Afrique sont devenus de grands innovateurs dans les programmes de filets sociaux et ont vraiment franchi des frontières et innové en termes de technologie pour pouvoir développer leur plan de mise en œuvre de la protection sociale. Et maintenant, d'autres régions du globe apprennent de nos efforts d'innovation et de construction de ces systèmes. Et je parle bien des systèmes parce qu'on est là non pas sur une approche programme, mais sur une approche de système. Next slide, please. Next. Je ne sais pas si j'ai un décalage. Next slide. Voilà. Donc, pour illustrer l'intérêt de l'expérience en protection sociale des pays africains pour le développement de l'auto-soin, je vais prendre un seul exemple, bien qu'il y en ait plusieurs. Donc, précédemment, nous l'avons vu, les recommandations de l'OMS indiquent que la création et le maintien d'un environnement propice pour offrir l'auto-soin de manière sûre et appropriée doivent être informés, entre autres, par le profil des utilisateurs potentiels. Donc, qu'est-ce que ça veut dire? D'abord, ça c'est directement lié aux approches centrées sur le cycle de vie et sur la personne nécessaires pour l'avancement des soins de santé primaires et la couverture sanitaire universelle. Pour informer efficacement, le profil des utilisateurs potentiels doit être utilisable pour la prise de décision et aussi pour la mise en œuvre programmatique. Cela signifie concrètement que ce profil doit permettre de décrire les utilisateurs potentiels au sein de la population, décrire leurs caractéristiques et décrire leurs besoins. Et enfin, ce profil doit aussi permettre de créer des catégories qui sont pertinentes pour l'élaboration des réponses à apporter aux besoins spécifiques des utilisateurs par l'auto-soin et de pouvoir retrouver ces utilisateurs afin d'assurer le suivi de la performance des interventions. Le profil doit donc être basé sur des critères utiles et utilisables pour l'auto-soin. Il se trouve que les programmes nationaux de filets sociaux du secteur de la protection sociale sont des programmes ciblant des individus et des ménages. Pour les mettre en œuvre, les gouvernements ont dû créer des systèmes d'enregistrement des ménages permettant de catégoriser en décrivant et de sélectionner les bénéficiaires des programmes sociaux, le tout dans un contexte où une grande partie de la population ciblée, pauvre et vulnérable, n'est pas enregistrée par exemple à l'état civil et œuvre dans le secteur informel. D'où une grande difficulté à repérer les gens, à les informer sur leurs droits et à leur permettre de réclamer leurs droits à la protection. Donc, pour ce faire, des registres sociaux unifiés, registres sociaux uniques, ont été mis en place et graduellement, une quantité croissante d'informations a été enregistrée et actualisée, mettant en connexion la demande et l'offre sociale. Cette masse d'informations est une source unique de données qui décrit la population dans les pays d'Afrique. Elle permet, entre autres, de répertorier et de localiser les vulnérabilités. Elle est en lien avec les grands axes de développement, éducation, santé, nutrition, pauvreté économique. Elle fournit des données utilisables pour des analyses individuelles ou statistiques sur les ménages ou les individus. Mais au-delà de décrire la population pour la sélection de nouveaux ménages ou individus qui seraient éligibles aux prestations sociales, les registres sociaux intègrent aussi, graduellement, les informations sur les ménages ou individus déjà bénéficiaires de prestations sociales. C'est-à-dire que cela permet de savoir quel ménage ou quel individu reçoit quel type de prestation. Et cela permet une coordination et une complémentarité des interventions des différents secteurs, parce que les différents programmes sociaux relèvent des politiques sectorielles et donc des ministères concernés. Cette collaboration intersectorielle est particulièrement essentielle dans le cas de l'auto-soin. Si l'on pense aux facteurs de l'environnement propice tels que l'accès à la justice, à l'information ou l'éducation, ou encore l'autonomisation économique, ces facteurs relèvent davantage des compétences de travailleurs sociaux aujourd'hui que de celles d'agents de santé communautaires ou de professionnels de santé. Donc, un raisonnement similaire peut être tenu pour plusieurs aspects de l'auto-soin qui pourraient utiliser l'expérience de l'intersectorialité et du dialogue politique transversal que la protection sociale a dû utiliser, améliorer et renforcer pour élaborer ses plans de mise en œuvre depuis 10 ans. Next slide, please. Next. Merci. Donc, pour conclure, la réussite de l'auto-soin dépend d'un dialogue politique dûment informé. Le droit humain à la santé est traduit dans les engagements des États pour les soins de santé primaires qui sont sous-tendus par une approche centrée sur le cycle de vie et une approche centrée sur la personne. La contribution de l'auto-soin au progrès de soins de santé primaire renforcera la réalisation du droit à la santé grâce à la création et au maintien d'un environnement propice. Et un tel environnement doit être informé par le profil des utilisateurs potentiels, services proposés, environnement légal, politique et obstacles. Donc la construction d'une telle connaissance ne repose pas sur un seul secteur ou une seule organisation ou un seul type d'acteur. Elle nécessite une collaboration intersectorielle et multi-acteurs, mais également un processus rigoureux d'analyse, de dialogue et de communication sans lequel les solutions élaborées risquent d'être incomplètes ou erronées ou inefficientes en termes de coûts. Par exemple, bien souvent dans les actions de plaidoyer, de nouvelles dispositions légales ou politiques sont réclamées, alors qu'une analyse du paysage politique et l'utilisation d'outils de communication stratégique montrent que des lois existent et que le problème réside avant tout dans leur application. Et l'analyse permet de comprendre pourquoi elles ne sont pas appliquées et d'attaquer les vraies barrières. Il ne s'agit pas pour moi de proposer ici des solutions, mais vraiment de soulever la question des cadres de collaboration à mettre en place pour le développement de l'auto-soin en tant que partie d'un système de santé durable, performant et équitable. L'engouement justifié pour l'auto-soin, conjugué avec une réflexion souvent en silo, mène parfois à se focaliser sur les recommandations de l'OMS sans analyse approfondie des ancrages existants dans les contextes nationaux et donc à oublier de considérer les atouts que nous possédons. Au Sénégal, la réflexion conjointe de l'auto-soin pour la santé sexuelle reproductive avec celle des maladies chroniques a permis d'utiliser des expériences propres au contexte sénégalais et d'enrichir fortement l'élaboration du guide national. L'élargissement aux autres ministères également en charge du bien-être social à travers leur mission de protection, de promotion et de justice sociale permettra de renforcer la trame de durabilité de l'auto-soin. Et ceci sera un atout majeur pour la prise en compte dans les budgets nationaux. Il s'agit alors d'adopter une approche stratégique permettant de définir, d'analyser et de comprendre ensemble les atouts et les lacunes de notre système pour créer des solutions adaptées. Cela demande que nous définissions des objectifs clairs pour un dialogue politique basé sur des informations probantes et construit grâce à des outils performants. Le contexte actuel de l'élaboration des guides nationaux d'auto-soin et leur mise en œuvre efficace demande donc que dès à présent et dès le départ, on entame ce dialogue intersectoriel et multi-acteurs. Je vous remercie beaucoup et je repasse la parole à Christy. Merci. Next slide.
Thank you so much, Aissata, for that presentation. I mean, for successful implementation of self-care, it definitely calls for a multi-sectoral collaboration, because it's not a one, and really nobody can work in silos really, because it borders on a lot of sectors. And for us to be able to profile potential users, we need to work with social workers and work with all the existing structure to make sure people that really need to practice self-care get to hear about it. Thank you so much. All right, please, if you have any questions, you can put it in the chat box and we will address it. The speakers will address it. All right, so we would go to our roundtable. We have a roundtable discussion, and this will be, I'll be calling on the speakers, Dr. Lucia Pizzarosa, I hope I got that correctly. Will be joining the roundtable. Dr. Moses Mulumba, Director of Center of Health, Human Rights and Development, and also Professor, okay, so these I have been practicing to pronounce, Charlameng, okay, so he would help us pronounce this. He's the Minister of Health for Burkina Faso. And he is also a doctor of medicine, specializing in gynecology and obstetrics, and the president of the Regional Council of the Order of Physicians since 2018. All right, so let's welcome them. So I will direct this question first to Prof, who will, Dr. Austin, talked about the legal and the policy mapping that was conducted. And I just want to know, how can legal and policy mapping inform opportunities to advance self-care in the current climate? Sorry, Aissata, were you trying to say something?
No, it's okay.
All right, thank you. All right, over to you, Prof.
If I may just briefly, just to answer to that, if I may just briefly, one of the issues in self-care is measurement. So at the moment, the policy mapping tool that was developed was a pragmatic tool to try to understand the state of play in some settings. As time develops and things develop, I think there's going to be a lot of emphasis on collecting objective data, for example, on the type and volume of SRHR products sold, for example, the number of policies and white papers that actually reflect self-care and the logic and the control statements and so on. So that was my brief answer on that, but I'll pass back the discussion to the roundtable. Thank you.
All right, thank you. So we hand over to the Minister of Health for Burkina Faso.
Oui, bonjour. Vous m'entendez?
Oui, très bien. Bonjour, Monsieur le Ministre.
Et bonjour, j'espère que tout le monde va bien. Alors, nous sommes contents de participer à cette table ronde pour parler de l'auto-soin. Moi, je suis Charlemagne Ouedraogo, je suis le ministre de la Santé de Burkina Faso. Alors, en ce qui concerne la cartographie des environnements légaux et politiques au Burkina Faso, nous dirons que la cartographie des environnements légaux et politiques en matière d'auto-soin nous paraît indispensable. En faisant le point des différentes politiques, stratégies, directives et réglementations développées dans le domaine, nous pourrons répertorier les gaps existants. Elle permet de ce fait d'identifier les facteurs juridiques et politiques qui entravent la mise en œuvre de l'auto-soin dans nos pays, particulièrement au Burkina Faso. Cette évidence pourrait motiver les autorités sanitaires que nous sommes à envisager de fortes actions en vue d'adresser les solutions aux différents goulots d'étranglement identifiés. Alors, comment pouvons-nous réussir ce pari? Eh bien, c'est en faisant en sorte que le maximum de départements concernés soient informés sur toute la chaîne depuis la communauté avec les agents de santé à base communautaire jusqu'au niveau central, de sorte à ce que tous ces éléments soient inclus dans nos différents documents de travail. Voilà donc pour ce qui concerne le premier point, ce que je pouvais déjà dire en attendant la suite. Merci. Je vous repasse la parole.
Thank you so much. All right, so I'll call on Dr. Moses. You mentioned a legal mapping that was conducted in Uganda. We would like to hear more how this also would help advance self-care in the current climate.
Sorry, Christy, I think Moses is off the call. Is it possible to move to a different question?
Definitely, thank you, Natalia. All right, so Dr. Lucia, so we would like to look at how do changes, in the health system arising from COVID and of course the rising interest in universal health coverage influence the trajectory of self-care at national, regional, or international levels?
Thank you so much, and thank you for the question. I think this is something that has really gotten us thinking, right? I think the pandemic has pushed a series of policy and legal development that perhaps would have taken much longer to be adopted, right? And in my field, particularly in the field of abortion, it's very clear that there's a move towards less medicalized, simplified, no-touch protocols, etc. So we clearly see that while fighting the pandemic, there's a lot of very interesting innovations in terms of really trusting people. And when I say trusting people, I say in my specific field of abortion, but also with the pandemic itself, right? People are expected to assess their symptoms, decide when to reach out to the formal healthcare system, local remedies, etc., right? So I think it's very important to really capitalize on those gains and really build from that a discursive argumentation for self-care. And I think the first thing to take into account is that all of these measures, while very innovative, having crafted as rather temporary measures, right? All of them are tied to COVID-19 response laws or policies. So I think one of the things that would be very interesting for all of us to take on is and to see how can we push for these provisional quote unquote temporary measures to become the norm, because they have, as we were talking also about evidence, they have proven that they work pretty well. They have proven that they're acceptable. They have proven that cut back on the risk of contagions, and that, like as I was saying before, right, like simpler, less medicalized, no-touch protocols are not only desirable, but the pandemic has proven that it's possible and quite easy to implement. So I think it would be very interesting that we also touch upon that. And on the matter of evidence, for me, it's something that I've been grappling a lot, because I think in my field in particular, there's a lot of emphasis on quantitative data, and there's a lot of emphasis on data that has to do with quantifiable markers of, like, for example, safety, right? And as I work with communities on the ground, and as we did a series of interviews with people that accessed self-managed abortion in very restrictive contexts in Africa, namely Kenya, Nigeria, and 3 other countries, one of the main concerns, for example, had to do with the fact that self-managed abortion in a very stigma-ridden society was providing them with one of the components was the privacy, right? So the possibility to control when and with whom to share that particular health intervention. And that was, we conceptualized as safety, for example, and perhaps the task that we have as self-care trailblazers is to, like, push a little bit beyond our understanding of safety as purely an issue that has to do with public health, but rather to really encompass the trajectories to access, all of the social, legal, etc. considerations that people do when working around and or self-caring their own health. So yeah, just my 2 cents to that conversation. I'm looking forward to more.
Thank you so much, Dr. Lucia. And just before you go, so COVID-19, have showed us a lot of people could not access healthcare, when they needed it. And, as users of self-care intervention, right holders, how are we able to better influence legal and policy development around self-care? Yeah, Dr. Lucia, you're on mute. All right, so Dr. Lucia is still on mute. I would pass on to I'll pass on to the Minister of Health from Burkina Faso. If you can just let us know how self-care users of self-care intervention, are able to influence legal and policy developments around self-care.
Alors, il faut dire que l'avènement de la COVID avec ses conséquences néfastes sur le système de santé est une opportunité pour accélérer la mise en œuvre de l'auto-soin au niveau national, régional et international. En particulier au Burkina Faso, nous avons été frappés par la pandémie de la COVID-19 et donc l'auto-soin reprend sa place dans ce contexte afin que les gens puissent continuer à recevoir des soins sans pour autant se rendre dans les formations sanitaires. Et au Burkina, dans la perspective d'adresser ces conséquences néfastes, Plusieurs stratégies ont été développées par le ministère de la Santé. La délégation des tâches fait partie de ces stratégies. Et dans le cadre de la mise en œuvre effective de la stratégie de l'auto-prise en charge, le Burkina Faso a élaboré et validé le document national d'orientation sur la délégation des tâches en santé de la reproduction, family planning, VIH et nutrition depuis le mois de juillet 2019. Et ce document a été révisé en juillet 2020 pour y intégrer de façon précise l'auto-soin. Auparavant, le Burkina Faso avait révisé ses politiques, normes et protocoles au fin de se conformer aux lignes directrices de l'Organisation mondiale de la santé sur la question de la délégation des tâches. Ce qui fait du Burkina Faso un des pionniers en faveur des interventions d'auto-soins. En effet, depuis 2017-2018, il y a eu le démarrage de la phase pilote de l'auto-injection avec le DMPA en sous-cutané dans 4 districts sanitaires du Burkina Faso. Et en 2018, nous avons réalisé le développement de la stratégie nationale de soins de santé centrée sur la personne. Voilà donc ce que je pourrais dire pour cette deuxième question. Merci.
Thank you so much, Mr. Minister. Lucia, do you want to say something? All right, so I'll just quickly go on. So we're looking at the human-centered approach to self-care, and Isata talked about, how we need to come together. Different sectors have to come together to collaborate and fully implement self-care. All right, so looking at human-centered approach by national and social protection agendas, enable individuals and communities to exercise self-care. How can we incorporate the human-centered approach to for individuals and to enable us implement and exercise self-care? Yeah, Dr. Lucia, please. Do you want me to go over the question again?
Sorry, I have a construction going on right above my apartment and they seem to have started right now. So like, if you could just skip me on this one and I'll join as soon as they stop a little bit. I'm really sorry.
That's fine. Thank you. All right. Sorry, Mr. Minister. I would have to take this to you. Okay, I'm not sure if he's still here. Okay, yeah, please. Okay, Dr. Austin, are you here?
I don't know if maybe we could repeat the question.
Hi, apologies for that. I was on mute. Sorry, what was the question again, Christine?
Yeah, the question is how can the incorporation of a human-centered approach by national social protection agendas enable individuals and communities to exercise self-care?
Really interesting question, thank you. So human-centered and person-centered, maybe they're slightly different concepts. Person-centered medicine, person-centered approaches are key for self-care because these are acts that we do for ourselves. I think a human-centered approach would talk to, what is appropriate, what is right, what is legal with some aspects of rights and responsibilities. I think ISATA may be better placed to answer that, but ultimately, self-care interventions need to be person-centered. They need to be ethical. They need to be ideally gamified and attractive for people to self-care on a day-to-day basis. A lot of us know how to self-care, but we choose not to. For example, we may take in excess alcohol, or we may smoke, and so on. There are many self-care products and technologies available that sometimes we don't use, we may not know about, or they may be expensive, or we adopt a lifestyle that is counter to that. I don't think I've answered the question, but I think to bring the person and the centeredness is very important to this. Frameworks, guidelines, interventions, policies should address that. And that's why health literacy and education is important, to embed these behaviors from a young age. Because once we're old enough, as our experience shows, it's quite difficult to change behavior. So I'm gonna maybe pass this to Aysata. She may be best placed to discuss the human-centered aspect of that.
Thank you, Austin.
Yeah, thank you, Austin. I think when we talk about person-centered approach, we are talking about the service itself. We are talking about the supply chain and how the service is delivered. And it can be, or it can be just based on centering of the person. Something important to keep in mind is that having a person-centered approach means organizing your offer of service around the need and the preference of the person more than around the disease or the disease. So it means that your system is not going to be uniform. It's going to adapt to different contexts. So it will be more cost efficient, obviously, because you will have the right service for the right person at the right moment. Now, if we talk about human-centered approach, there are two things. The first thing is that relating your, let's say, technical or service offer person-centered to a human-centered approach means you directly linked it to government accountability, to the fact that having access to proper health care at the proper time means realizing the right to health. Sorry for my English. Right to health for everyone. So it's not distinguished. It's really reinforcing the point about duty bearers and right holders. Actually, it is not because you have a person-centered approach that you are respecting rights, but if you are underlying it with human-centered approach, that is always taking into account that the government has to protect, promote, and respect and realize the right for health, because it is enshrined in our constitutions, because it is enshrined in human rights. This is important. And the second thing about human-centered approach, human-centered system, is that very often we forget that the people that are implementing the system are just human beings. And this is something very important, I think, more on our continent. If we forget that the system is implemented by some human beings that are with their own vulnerabilities, that are at risk themselves, if we talk about this health worker, for example, we forget a huge part of the risks that can jeopardize the system performance. So this human-centered approach means also analyzing your health system in a way that it is really considering why people are staying or not at that work, why they are efficient, why they are not, or why they care or they do not care. It's not because you are a civil servant that you are going to be perfect. And I think we very often forget that the system does not exist without these human beings implementing the system actually. And this person-centered approach based on human person approach is something that was very developed in social protection for most vulnerable because of this persons being at the center of the system performance actually. Over to you, because I could talk about that during hours, so it's enough, I think.
Thank you so much, Aysata. Yeah, for bringing in that perspective, and also Dr. Austin. So I think I'll just do a round robin with this last question. And we want to look at what actions would support the development, adoption and implementation of evidence-based laws and policies to improve health systems performance through self-care. So what actions should we be looking at that can support the development, adoption and implementation of an evidence-based law and policies to improve health system performance through self-care? And I will start with Lucia, Dr. Lucia, if she's available. Okay, she said it's super noisy, so we would move to the Minister for Health, Burkina Faso.
Alors, merci. Pour cette dernière question, je dirais que pour améliorer la performance des systèmes de santé grâce à l'auto-soin, il faut que les responsables des politiques de santé ouvrent ensemble un débat concernant leur rôle dans la protection et la promotion des droits et de la santé des femmes et des enfants, ainsi que dans l'élimination des obstacles que ceux-ci rencontrent. Les actions qui soutiendraient l'élaboration, l'adoption et la mise en œuvre des lois et politiques basées sur des données probantes pour améliorer la performance des systèmes de santé grâce à l'auto-soin pourraient être, premièrement, le renforcement du système d'information sanitaire en y incluant des indicateurs relatifs à l'auto-soin par le biais de l'évaluation des stratégies innovantes suscitées. Le renforcement de la recherche en santé sur les questions d'auto-soin en associant les instituts de recherche ainsi que les sociétés savantes. Le plaidoyer auprès des gouvernements et des parlementaires en organisant des sessions d'information et de plaidoyer forts sur l'auto-soin. Et enfin, la mobilisation des ressources domestiques et externes pour financer l'activité. Voici ce que j'avais à dire pour cette dernière question. Merci. Je vous repasse la parole.
Thank you so much, too. And I totally, we need to keep reinforcing every evidence we get on self-care and also provide information for everyone to make informed decision. Dr. Austin?
Thank you, Christy. Please, would you mind just reminding me of the question again so I can be more focused?
Yeah, we're looking at actions that will support the development, adoption, and implementation of evidence-based law and policies to improve health system performance through self-care.
It's evidence-based law, and law ideally would be evidence-based decision-making. And that's where we come back to, where is the evidence for self-care? It's actually quite difficult from a scientific perspective to find an effective self-care intervention. We know of a few, of course, they're in the guidelines and there are others. But that is because if you pay for an intervention in health, you may get the benefits, not in the health system, but in the social care system or in the community health system and otherwise. So there are now mechanisms to try to determine if self-care in its totality is cost-effective. So we have a lot of evidence specifically for self-management of diabetes using remote monitoring of glucose, for example, but you can't then generalize about self-care in its totality. So more awareness about the self-care movement, policy, control statements in the policy, national commitments for Horizon 2030 and beyond. What would countries and governments want to put in place to ensure that stakeholders can self-care if they want? Looking at the roles of pharmacists and prescribing rights and roles and the role of point-of-care tests and technologies in that. I think, and also who are the self-care vanguards in the world? So, we say that the UK has a self-care forum. Australia now has a self-care forum or a self-care alliance. And there are many stakeholder groups forming in Nigeria, Uganda, and otherwise. So I think to incorporate the language of self-care in policy documents is very important. If you do a word search in policy documents in the UK, even in the prevention agenda, you rarely find self-care in a prevention agenda, which should be talking about self-care. So that's my take on that.
Thank you so much, Dr. Austin. Aisata?
I think Well, first thing, when we talk about research or scientific aspects, I read in several documents and even in the WHO guidelines that there is a need for research, and my claim would be, how is African research involved? As I am working in Africa, of course, but we need to better know. And of course, you understood that I come from social protection, and I see a lot of common challenge because of the lack of model, because of the specificities of our context. And then I think we need to learn from our past also, and we know now that we need really to build some specific research agenda for self-care with research centers in Africa. We need to connect Anglophone context and Francophone context. Anglophone context is ahead of Francophone context, and we need to learn from what was done. And this is something that is insufficiently done. Actually, this is why I made my presentation in French, because I just wanted to claim for more Francophone inside there, but it's really a need. So for me, I would send back the question to everyone actually to say, okay, how could we really build this relationship between both sides of the continent in Africa, while everybody's talking about self-care, but today it is very difficult to find anything on self-care accessible for Francophone government, researchers, or anything. The second thing is that the link, as I said, focusing on the guidelines in WHO guidelines, when you read the world version, there is a lot of things, and the two components regarding governance and sustainable financing, for me, are not sufficiently developed. There is no clear things for me linking the supply chain, service offer, and the sphere of decision making or policy making. And this link is missing for me, because it would be a wonderful way to link the dialogue between all the different stakeholders, because this is where things are happening. The last thing is, how do we consider that the place where self-care is taking place? It is not taking place at national level. Yes, this is where things are reflected. This is where laws or policies or decisions are made. But actually, when you need some self-care, when you are a self-carer or self-care user, you live in your village, you live in your small place. And I didn't see the link with the different level of responsibility and accountability that are legally defined in our laws regarding decentralization, for example, which has specific, let's say, breakdown of responsibilities and accountabilities on legal level, depending on you are being a mayor, you're being in the decentralized level of authorities or in the administrative authority. And this is not, for me, taken into consideration enough. Why there are some very interesting things happening now in some countries, linking decentralized authorities, administrative authorities, and civil society activities, actually. So we have a lot to analyze in the field to be able to really see how we could improve this dialogue and, well, defining the needed action, actually. Over to you.
Yeah, thank you so much, Asaita. We have a lot of conversation in the chat, and thank you all for contributing to this discussion. I would hand over to Catherine Mayel, who would, of course, give the concluding remarks for the session.
Thank you so much. And thank you so much, everybody, for joining us today. I think I wanted to just build on some of the points that Aissata made about the actions that would support the adoption and implementation of evidence-based laws and policies around self-care. And I think in particular, one thing that I would challenge us to do is really differentiate where there's actual gaps in evidence versus where we're just facing political opposition, and in particular around self-care and SRHR. And I think it's important for us to recognize and call out where that political opposition is really based in either stigma around SRHR, moral beliefs or justifications that people shouldn't be, sexually active or accessing these services, and also discriminatory beliefs about women and certain groups of individuals and their ability to practice self-care. And I think that we need to, keep an eye on disentangling these things and really recognize where really that belief underpinning people's ability to make, what are seen as responsible or good decisions about their lives and health are actually contributing or continuing to be a factor that prevents implementation of and adoption of self-care measures. The other thing I would just say as far as what we need to be doing is continuing to organize ourselves as civil society and to exercise the voice that we have and to make sure that we are actually holding governments accountable for their obligations and making sure that they understand that self-care is a key component of human rights and of individuals' ability to exercise the right to health and the full range of their human rights. And finally, I just want to recognize the importance of the advances that have been made by international institutions in this regard and the importance of that leadership. I think the WHO self-care guidelines are so critical for starting to move towards kind of dismantling that political opposition. And there's so much more that can be done, both if we can combine the leadership on the ground and the power of civil society advocates on the ground with the power of some of these leading institutions that can really show that the evidence base is there and that there's really an opportunity for both enabling people to exercise their rights, but also ensuring that health systems are actually functioning more effectively and that we are creating healthier populations through the use of self-care. So those are just some final reflections that I would leave us all with. So as we wrap up our session, I just want to point out that there's a place to provide feedback that's in the chat. And so we encourage folks to provide feedback. And just to say thank you to all of you. Thank you to our esteemed panelists and presenters for joining us today. And we've really enjoyed this active conversation. Thank you to our moderator, to Christy, as well. And thank you so much to all the folks at the Self-Care Trailblazer Group for coordinating this and making this session possible.
Thank you. Goodbye. Thank you.
Thanks, everyone.